Good day, everyone. Thank you very much to the organizing committee for a chance to present our work. This is a paper that looks at laparoscopic liver resection, a cost analysis in a middle-income country for the uninsured population. So as we know, laparoscopic liver surgery is being used at an increasing rate worldwide, and this applicability has been encouraged by technical innovations and modifications to the technique over open surgery. And that has been largely due to developments of technology involving better imaging as well as energy devices. At the first iteration of this meeting held in Paris in 2017, it set out to consolidate and homogenize the indications, the techniques, and the strategic approaches in laparoscopic liver surgery, which it was successful at doing. With regards to laparoscopic liver surgery versus open surgery, there's certain well-known benefits, and these are almost become generic to laparoscopic liver surgery or laparoscopic surgery in general, including lower post-operative morbidities, shorter length of stay, lesser pain, lesser blood loss, and lower post-operative readmissions. Now, what we need to understand is that from an economic perspective or from a financial perspective, the comparison of laparoscopic and open liver surgery is particularly challenging and difficult to do. And the main reason for that is there's this heterogeneous group within liver surgery, including both major and minor liver resections, which certainly has cost implications. There are intra and post-operative costs. Countries largely differ between their reimbursement patterns, and those are almost country specific. So comparing them between countries is quite a difficult thing to do. And then you've got with laparoscopic or with liver surgery, you've got your classic cost drivers, which were mainly post-operative complications. But now with laparoscopic surgery, in addition to these classic cost drivers, you have additional specific laparoscopic costs, and those include things like expensive consumables, including staplers, laparoscopic accuser, etc. So just to give you some background, we are based at Dr. George Mukhari Academic Hospital, and it's affiliated to the Sefako Makgato Health Sciences University in Pretoria, South Africa. This is a tertiary academic center. It is a major laparoscopic center in South Africa, and the population that is serviced is approximately 4 million people across 4 provinces of the country, and there are also a significant number of patients that come from our neighboring countries. And the main challenge that we face is we need to try to offer tertiary level services at a high international standard of care, but we do have to acknowledge that we are working in the constraints of a resource-limited country. So the aims of our study were to review the financial implications of laparoscopic hepatic resections, major and minor, at our academic institute. And we wanted to establish whether there was any clinical or cost advantage to laparoscopic liver surgery. This review does have wider implications in terms of the South African/African context. So we conducted a retrospective review from a prospectively maintained database. All laparoscopic liver resections performed at George Mukhari between January 2017 and January 2021 were reviewed. And this period looked over a time where we were staging an introduction of these laparoscopic liver resections at our institute. Therefore, we have both open and laparoscopic resections. So the demographics were maintained on our database, and you can see here on this slide, there's a wide array of data that's maintained, including factors related to the tumor, the operative technique, operating time, the equipment that's used, the length of time in both ICU as well as high care, and the overall stay, complications, mortality, and the diagnosis. So in terms of the patient selection, so any patients required liver resection were identified by our HPV team. The decision was made by one of the senior consultants in the unit. Standard workup were performed for all these patients, including imaging, and the patients were discussed at a multidisciplinary team. We use the Brisbane nomenclature or the Brisbane consensus to describe the types of liver resections and whether they were minor or major. No hybrid techniques were used. If any additional resection, for example, a colectomy or gastrectomy, etc., was performed with the liver resection, those were excluded from the analysis. So anything other than a cholecystectomy was excluded. And the patients were matched between the control group and the comparator group for open as well as laparoscopic resection. And we used the intention to treat principle to analyze the data. So if someone underwent a laparoscopic resection but was converted to open, they were analyzed within the laparoscopic group. So cost analysis, we use the standard tariffs that are set by the Department of Health of South Africa. And if you look at costs, because the doctors and nurses are salaried in the state-run hospital, the operative costs are largely driven by the equipment and the consumables used, as well as the post-operative hospital stay. Theater use in the public sector, theater time doesn't factor in as much, whereas it's billed by the minute in the private sector, as well as in most developed countries. This is not a huge cost in the public sector. So we looked at theater supplies, depending on the approach, blood transfusion, number of days in ICU or high care, overall hospital stay, and complications that needed management and the cost. And all the costs are done using rands in 2017. And as we know, that's quite volatile and very fluctuant against the US dollar. So the statistical data, these were analyzed with the statistical software of Strata for Windows. Median and range were considered for continuous value variables, and their value distribution was skewed. Mann-Whitney U test was used to compare continuous variables. Chi and Fisher exact test for categorical variables, and the statistically significant P was set at 0.05. So you can see here we had 80 resections, 40 laparoscopic, 40 open, and a mix of major and minor. You can see the balance between the laparoscopic and open, both in terms of major and minor, in terms of the indications. These are the demographic profiles. So you can see a slightly older median age range. Now, if you look at this slide, you can see in terms of our major resections, the blood loss is reduced compared to the major open resections. However, there are some patients that do bleed significantly, even in the laparoscopic group, and that's in keeping with international data. This was not statistically significant. Less blood transfusion, shorter length of days in ICU or high care, less total length of stay, and less overall post-operative complications. Mortality was not significant between the two groups. In terms of cost, you can see the cost for the major, I'll just focus on this one, major laparoscopic liver resections was slightly more than that of the open liver resection. So this was largely driven by the consumables and energy devices that were used, but to some extent the cost was offset by the shortened length of high care / ICU stay. So if we look at the average cost of hospital stay in South Africa, it's around 2,000 Rand a day. If you have a reduction of 4 days on average in hospital stay, that amounts to about 8,000 Rand reduction with laparoscopy. But this is counted by the increased cost of consumables. So the cost saving does not include an overall earlier return to work and an impact on quality of life, which does have a broader economic impact. So in conclusion, laparoscopic liver resection is comparable to open surgery in terms of the economic implication. The cost is slightly higher in terms of the operating costs with consumables, where it was not statistically significant. That cost is largely offset by the shorter hospital stay, reduced blood loss, and less complications. So laparoscopic liver surgery is a viable option in the setting of a middle-income country and does not pose prohibitive operative cost to its wide implementation. Thank you.